So diabetic foot is a big problem worldwide. It is as big problem we have in India as we do in England where I work. So the problem we were facing when I joined the diabetic foot multidisciplinary unit in London at King's College Hospital about 17 years ago was that deformed diabetic feet. What happens in diabetes is because of the damage to the nerves, vessels, and the bones, the foot gets twisted and deformed. And unless if you untwist the foot and correct the deformity, the patient can't walk well. And patient with diabetic foot problems, if they can't remain mobile, they develop bigger problems. Their heart gets weakened, they develop kidney problems, they develop problems with brain circulation resulting in stroke, and so on. So it is really important that we maintain their mobility. And taking the leg off, amputating the leg is not ideal in those group of people either, because those people, people with diabetes, if they lose their leg, there is so much scientific evidence available for more than 3 decades that they end their life early. If a person with diabetes, if they lose their leg, many of them die, about 60 to 70% of them die within 5 years, which is not acceptable. So we decided to try and develop a more reliable surgical technique and develop the instrumentation and special devices to provide a reliable and predictable solution for these really complex problems. So at this unit where I work and I head as a reconstructive lead at King's College Hospital Diabetic Foot Unit, and I have done more than 170 specific special complex diabetic foot reconstructions, and we are very pleased with the results. And those the results are globally recognized, and many countries follow similar protocol. And I feel so fortunate to be able to provide that service to my people in India, and I'm so grateful to Apollo and my friend Dr. Srinivas for joining up with us to deliver this service to our own people. So I do understand that it is not easy to fully understand how much problem a diabetic foot, this deformed diabetic foot, can create. So we thought it would be useful to go through a couple of case examples, and then if I could explain to you using this presentation, and just to let you know how this problem comes out as. Now this patient is now a 54-year-old, but she was 51-year-old when she came to me, referred by my another orthopedic surgeon from far distance in England, and she also went to that doctor with a twisted diabetic foot problem. The foot is deformed. So basically, if you look at the bones here, they're all out of position. Normally, the foot bone, the foot is made of bones arranged perfectly in certain geometry. So in fact, those doctors had tried to correct the foot deformity, but that failed, and that got infected. And you can see the amount of disease called infection bursa, and the patient can't walk, and the patient hasn't been able to walk for a long time. So the option given to her was an amputation, because they tried, it didn't work, it was getting infected, the patient was getting sick, but she was referred to us. In fact, most patients that come to us are recommended amputation elsewhere. So technical details, we're not going through technical details, but what we do is, because that was badly infected, the first thing we need to do is to get rid of that infection first. So we do an operation where all the infected bone is removed. And then we wait for everything to heal. So the goal here is to eradicate that infection in the bone, in the tissue, all of that. So when we eradicate that infection, the bones wake up and the bones can start healing. So we go back in again after, on this occasion, after about 2 months, and using all these more specific, special devices, I fixed the whole foot and ankle part, and the bone healing. In those x-rays it shows full bone healing, and because the bone has healed, the rods, screws and plates, they provide good stability, the patients can walk. That's what we are trying here. You correct the shape of the foot, make the foot very strong so that the patient can walk. If the foot looks normal and if the foot is nice and stable, it allows the patient to walk. I would also like to share this patient. This was the first patient I did as a 2-stage procedure more than 10 years ago, and many patients wanted to know how they do over the long period. So again, some shocking images. Patient was seen by multiple doctors and multiple hospitals, and with very bad infection. And this X-ray shows many bones have disappeared. The black area means there is air shadow, the air from outside, because the ulcer was so bad, the air from outside went in, and that usually is an indication for amputation. But the patient was desperate to keep the foot. So again, with cleanup operation, the wounds heal. When you do proper cleanup surgery and remove all the infected material, even in diabetes patients, the wounds heal. And again, my colleague Dr. Srinivas does a lot of these cleanup operations, and we get very good results. And then using that special technique I mentioned to you, I fixed the bones, and these were very old-fashioned bones. They were not even modern devices, because 10 years ago modern devices were not available. So even with the devices that were normally used in other parts of the leg, I had no choice, use them. But interestingly, 10 years ago, and you can see the foot shape looks normal, the wounds have healed well, the bones have healed well, and she has come to my clinic recently, and she reminded me that it was her 10th anniversary. So she wanted to take a photograph, and she was happy for her face, and we don't like to reveal the patient identity, but she was happy and she wanted, she was happy for that. So, I mean, you can't, she can regain good mobility, but you can't go back to a very, very, you can't run, or you can't climb mountains. The situation where she was going to lose her leg and she was unable to stand or walk, and she has been able to look after herself, and that was her 10-year anniversary. So these examples are just to give you a flavor on the kind of problems we are going to deal with, we have started dealing with in our Center of Excellence unit, and with already a well-established primary diabetic foot care through sugar clinics. This is an amazing, Apollo has unbelievable, amazing network of primary care for diabetic foot people. So that primary care will protect millions of these patients, but some of them develop bigger problems, and those patients require secondary care. And we already have a fantastic center here in Jubilee Hills, headed by my colleague Srinivas, providing all of that secondary care. Means if there is an ulcer, if there is a bit of shape abnormality, and that service has been available. But what we're going to introduce from now on, which hasn't been available in this country in a structured manner, is to provide that high-end tertiary care. Those patients that come with severe deformity, or foot becomes too wobbly, unstable, if the infection gets bad, all of these normally are managed with amputations, usually in many centers. But what we're going to offer is this advanced diabetic foot limb reconstruction service. The goal here is not to just to retain the limb, but to retain the function as well, so that the patient can weight bear, can walk, and can have a decent lifestyle. So, and I thought that these two cases would actually give you a flavor on the kind of service the patients can expect from our new diabetic foot limb reconstruction component of the Center of Excellence in here at Apollo, Hyderabad.